If we look at the musculocutaneous nerve, it's one of the anterior division nerves, and it in fact innervates all of the anterior muscles of the arm. Period. So there are no exceptions. All musculocutaneous nerve, the only muscles that innervates are the anterior muscles of the arm, and all of the anterior muscles of the arm are innervated by the musculocutaneous nerve, which means it's not really that important to worry about the individual muscles, since they're all innervated by the same nerve, and they fundamentally have the same function. They are elbow flexors, primarily with some shoulder flexion as well. So that means that a musculocutaneous nerve injury will affect the anterior arm muscles, which would affect elbow flexion. The median nerve. Well, the median nerve innervates almost all of the anterior muscles of the forearm. So when we look at the anterior forearm, firstly, as a generalization, we can say that the function of anterior forearm muscles is to flex the wrist and flex the digits as their major function. So you should think of the median nerve as a nerve responsible for wrist flexion and digital flexion. And the median nerve innervates almost all of the muscles of the anterior forearm. But I said almost. There are exceptions, and more specifically, 1.5 exceptions. So there's 1.5 muscles of the anterior forearm that are not innervated by the median nerve. So rather than learning all the muscles of the anterior forearm, we just need to know the 1.5 that are not median nerve. And then we can say that if a muscle of the anterior forearm is not innervated by the median nerve, it's going to be innervated by the ulnar nerve, because it still has to be innervated by an anterior division nerve, and the ulnar nerve is the only anterior division nerve left. And so all we need to do is say which 1.5 muscles are innervated by the ulnar nerve, and then we'll know all other anterior forearm muscles are median nerve. And the 1.5 muscles innervated by the ulnar nerve are the 1.5 muscles closest to the ulnar nerve, meaning the 1.5 most medial muscles. So the most medial muscle is the flexor carpi ulnaris. The second most medial muscle is the flexor digitorum profundus. We only want half of that, so we'll have the medial or ulnar half of that. So it's the flexor carpi ulnaris and the ulnar half of the flexor digitorum profundus are innervated by the ulnar nerve. Everything else is innervated by the median nerve, the anterior forearm. Now we'll come back to the median nerve in the hand in just a moment. Let's first deal with the ulnar nerve. The ulnar nerve, we've said, does those 1.5 exceptions of the anterior forearm, but the major function of the ulnar nerve in terms of muscle innervation is to innervate the muscles of the hand. So almost all the muscles of the hand are innervated by the ulnar nerve, but again, I said almost. That means there are some exceptions, and the exceptions will be innervated by the median nerve. So we can think of the anterior forearm and the anterior hand as sort of being the opposite sides of a coin. Anterior forearm is mostly median, with the exceptions being ulnar. The anterior hand is mostly ulnar, with the exceptions being median. So we see all of these hand muscles being innervated by the ulnar nerve, and if we go back and look at the median nerve on the previous slide, we see a few muscles innervated by the median nerve. There are 5 exceptions in this case, but those 5 exceptions fall into 2 groups. One group is the 3 thenar muscles, and the other group is the 2 lumbricals in the central compartment. The reason the opponent's pollicis is listed separately here, it's one of the thenar muscles, but in terms of clinically important, that is the really important muscle of the hand that's innervated by the median nerve. And we'll talk about the specifics of that when we talk about nerve injuries. So we've done the musculocutaneous, the median, and the ulnar nerve, and we're finished with the entire anterior limb. That leaves us with 2 nerves, 2 posterior division nerves, axillary and radial. Axillary is very easy to deal with because although we see that the axillary nerve innervates 2 muscles, which is true, in reality, teres minor is not clinically important. It's really not possible to clinically test the the teres minor because there are so many other muscles that do the same thing that it does. So you can't isolate the teres minor. So the only thing that's important that the axillary nerve innervates is the deltoid muscle. And so we know that the deltoid is an abductor of the shoulder, so shoulder abduction should be associated with the axillary nerve by way of the deltoid muscle. So that takes care of the axillary nerve. And that leaves us with the radial nerve. We haven't yet innervated the posterior muscles of the arm or posterior muscles of the forearm. And so the radial nerve is a posterior nerve, and it innervates the posterior muscles of the arm and the posterior muscles of the forearm. All of them. All of them. And as we said earlier, posterior muscles largely are extensor muscles, and so the radial nerve is going to be responsible for extension of the elbow, extension of the wrist, and extension of the digits, at least as far as the metacarpal phalangeal joint is concerned. Okay, so that takes care of the posterior compartment. There are no posterior muscles in the hand, so there's no muscle innervation by the radial nerve that goes into the hand. Now, what we've just discussed, those 5 terminal nerves, is what we need to know if there are injuries to any of those 5 nerves. The 5 terminal nerves, we now know where they go, so we should know what kinds of functional losses to anticipate. But that still leaves us with the question of what if the nerve injury is not at this level of the plexus, but rather at this more proximal level of the plexus? In other words, what if the injury is at a segmental level to the roots of the plexus or to the spinal nerves that contribute to the roots of the plexus? How are we going to know what muscles will be affected by that? So that means that in addition to knowing which specific nerve innervates which muscles, which is what we just covered, we also need to know what the segmental innervation is of the muscles of the upper limb. And although that's a separate pattern of innervation to learn, it's very easy to learn because there's really just one principle that we need to know, and that's listed here, which is that the segmental innervation to the muscles of the upper limb has a proximo-distal gradient, which means that the more proximal the muscle is, the higher the level of innervation. The more distal the muscle, the lower the level of innervation. And if you combine that principle with the knowledge that almost every muscle in the upper limb is innervated by at least 2 consecutive segments, that means we don't have to know, is a muscle a C5 muscle or a C6 muscle, for example. It'll be a C5 and C6 muscle. So combining the notion that we have 2 consecutive segments involved in the innervation of muscles and that there's a proximo-distal gradient, that means the most proximal muscles, the muscles around the shoulder, are all going to be innervated by C5 and C6, regardless of which nerve innervates the muscle. Whether it's one of the collateral nerves, whether it's one of the terminal nerves, it will be a C5, C6 innervation. The most distal muscles means the muscles of the hand, and therefore they will be innervated by C8 and T1. Now, of course, the muscles in between, the muscles of arm and forearm, are going to be in between 6-7 and 7-8, but in reality, segmental lesions at this level are quite uncommon, and so questions about segmental nerve damage is likely going to be either to C5 and C6, which means it'll be shoulder muscles, or to C8 and T1, which means it will be hand muscles. So that takes care of the segmental motor innervation.